Welcome to our virtual grand rounds. And this morning, we're very excited to welcome Dr. Harish Seethamraju. Dr. Seethamraju earned his medical degree from Gandhi Medical College in Hyderabad, India, and after coming to the United States, pursued residency training at the Interfaith Medical Center in Brooklyn, followed by completing his pulmonary training fellowship at Baylor College of Medicine in Texas. His career thus far has included appointments as Associate Professor of Medicine at the University of Kentucky College of Medicine, and as Associate Professor and Medical Director of the Lung Transplant Program at Houston Methodist Hospital and Baylor College of Medicine. Most recently, prior to joining Mount Sinai, he was the medical director of the lung transplant program at Montefiore Medical Center. He has recently joined Mount Sinai as senior faculty within the Division of Critical Care Medicine and Cardiovascular Surgery, and is the inaugural director of the medical director of the Mount Sinai Lung Transplantation Program. Very warm welcome to Dr. Harish Seethamraju.
Thank you very much, Jim. Thanks for the great introduction. And thank you for giving me an opportunity to present the topic very dear to me. This is a small update on lung transplantation from the internist perspective. I have no conflicts of interest regarding this topic. Transplantation has been on top of minds of several innovative physicians for a long time. Notably, Vladimir Demikov tried to create a living, breathing, two-headed dog in 1959. The dates and the years are specific, and I wanted to go through that. And he showed that the two dogs were alive, and the transplanted head, the dog head, was able to drink the milk that is being offered. And in 1960, Christian Barnard performed the first successful human heart transplant, followed by the first successful lung transplant in 1963 by James Hardy from University of Mississippi. This was performed on an inmate with lung cancer, had a pneumonectomy, and had a lung transplant. Unfortunately, patient did not survive long, and he expired in 18 days because of anastomotic airway complications. That really put lung transplantation on the back burner until Joe Cooper, who was Dr. Hardy's resident, along with Alec Patterson from University of Toronto, really revolutionized the surgical technique that we practice today. Some of the names should go mentioned is Norman Shumway from Stanford and Bruce Rides. Norman Shumway has been on lung transplantation arena for a long time, and he has actually performed a successful heart double lung en bloc transplant because the anastomosis of the bronchus was technically challenging. And this was performed on a cystic fibrosis kit. And the patient survived for more than a year. This was published in 1981. So since then, transplantation has really taken up. And today we perform close to 4,000 lung transplants across the world. And most of them are double lungs as opposed to single lungs. What is the frequency of the transplants? Most transplants today are done in medium-sized programs. We hear about big programs in different states or in different countries. They do perform about more than 50 or 100 transplants per year. But most transplants in reality are performed in medium-sized lung transplant programs. The common indications for transplant are COPD, cystic fibrosis, idiopathic interstitial pneumonitis, and interstitial lung disease, which are secondary to rheumatoid arthritis, scleroderma, and other collagen vascular diseases. As time passes, we are trying to do double lung transplants preferentially in most diseases as opposed to single lung transplants. We believe double lung transplants offer a survival advantage as when compared to single lung transplant. And indications of transplantation are different in different continents. Often we hear that programs outside of our country have much better outcomes or worse outcomes than our country. But the indications are different in different continents. In our country, most common indications are COPD and IPF. In fact, idiopathic pulmonary fibrosis or idiopathic interstitial lung disease is the more common indication today in our country in most programs as when compared to COPD in Europe. Organ pool is a big challenge in lung transplants. I just want to share some of our OPO data that is on a public website. And we have the most number of deaths per square mile when compared to any other state. But our lung organ donations have been extremely low. In fact, we are the lowest in the nation when compared to any other state in the country. The reasons are multifactorial, but this is at large. This is a huge challenge in New York or tri-state area. Most of the organs that are available in our OPO actually end up leaving our area to other programs, Duke, New Jersey, Temple, Cleveland Clinic, University of Maryland, and Columbia performs has a big share of the organs that are available. One important take-home slide today from my talk is this one. When do we think about lung transplantation in a patient? Fortunately for us today, we have several predictors of survival in every lung disease. If the expected survival in a patient with an existing lung disease is less than 50% in the next 2 years, that's when we would like to see the patient, evaluate the patient, wait for an organ to come through and transplant so we can actually prolong their life. I will share a couple of slides about some specific diseases. This is what we call the transplant window of opportunity. This may be too early for transplant if the patient is okay, symptomatic, but still able to work with their activities of daily living. But when they are too sick and they can't even walk 600 feet in a 6-minute walk, then it may be too late for us to evaluate them because a transplant intervention is not going to offer a survival advantage. This is an important factor that determines several outcomes of every center too. If we have unlimited or a good number of donors, we will have the opportunity to list a patient early in their disease, actually try to find an organ and transplant within the window of opportunity to ensure a good outcome. This is a survival comparison and where transplant comes in idiopathic pulmonary arterial hypertension. Thanks to several of these great investigators and pulmonary hypertension and the survival has dramatically changed with the newer therapies that are being offered today. And these are the survival curves of patients in functional class 3 or class 4 with therapy based on the published data. And transplant is offered patients who remain in functional class 3 or 4 despite all available therapies or fail to progress. And that would be the indication to transplant, where you can offer a survival advantage than when compared to other medical therapies that can be offered in this group. A simple test that can be done in any clinic setting to determine if your patient actually would warrant an evaluation is a 6-minute walk distance. This is an extremely good predictor of survival in most lung diseases. I'm sharing an example of idiopathic pulmonary fibrosis. A patient who cannot walk more than 207 meters at a 6-minute walk distance has a 50% mortality in the next 1 year. This is in idiopathic pulmonary fibrosis. This kind of data really helps us to evaluate patients in a timely manner based on simple, repeatable, and easily followed by any clinic or any clinical center. And this happens to be a better predictor than actually the vital capacity in a restrictive lung disease, a simple 6-minute walk distance. The same stands true in COPD too. A 6-minute walk distance of less than 149 meters, the 1-year survival is only 55%. So in several diseases, a simple 6-minute walk distance can serve as a good indicator for a timely referral for a patient to be evaluated for lung transplant. How are lungs allocated? Lungs are allocated by lung allocation score. And what are the factors that are keyed into the scoring system? In 2005, our country has adopted a scoring system instead of the priority of number of days waiting on the list. This is primarily to increase organ transplantation in patients with lung disease. Increasing oxygen requirements, decreasing vital capacity, New York Heart Class 3, Class 4 symptoms, patients who are on non-invasive or invasive ventilator, a diagnosis of IPF, and high pulmonary artery pressure, also called secondary pulmonary hypertension. All these factors drive the score up, but a good 6-minute walk test, but patients need to be functional, a decent BMI. I wanted to point out the BMI because most lung diseases, we are tempted to use steroids and immunomodulators, and most of these have extended side effects. And if the BMI is greater than 30, the risk of the survival of these patients, even if we offer a transplant, is much worse. And a younger patient would always get a higher score than an older patient. In fact, in the pediatric age group, the organ will be offered to every pediatric patient in the country before it would be offered to an adult patient. So lung allocation score really drives the who will be offered a potential organ. Higher the score, the more chances that a person would get that lung from that area. 2 years ago, we have changed one key factor of organ allocation, which is instead of regional distribution of organs within a state, we have decided that 150-mile radius from the donor hospital, whoever has the highest lung allocation score would get the first shot at that donor. This is primarily to help or promote optimal organ sharing. And this has really helped the New York program. So we actually have access to donors from Philadelphia, or from Boston. Since the inception of these changes, there are increased number of lung transplants, decreased deaths on the waiting list, and increased frequency of transplantation in idiopathic pulmonary fibrosis. What are the general recipient selection guidelines? Obviously, we want to look for survival advantage after lung transplantation. And in any disease process, we have several predictors of survival based on their pulmonary function test, based on their PFTs, or based on their 6-minute walk test, and several other indicators. And we want to key in if we can offer a survival advantage. In COPD, we have not shown survival advantage with lung transplant, but we would perform lung transplant for quality of life, especially in older patients, age over 70, and also in COPD patients. And anticipated wait times with the regional therapies, and we would like to try every alternative therapy for specific diseases before we venture into lung transplant. What do I mean by that? In COPD, lung volume reduction surgery in the low-risk group offers a survival advantage. And that intervention has not been utilized in many countries. And we would like to look at a small subset of patients who would qualify for lung volume reduction surgery, and we would offer them that intervention as compared to lung transplant in COPD emphysema patients in the low-risk category. General age cutoffs that are followed across the countries, across the nation, in heart double lung for less than 55, for double lung less than 60, and for single lung less than 65. And they should be walking at least a good 6-minute walk test and a creatinine clearance of at least 50, GFR of at least 50. Absolute contraindications are if they have other end organ failure, as in cirrhosis, GFR less than 50, or EF less than 35%. These would be absolute contraindications for just lung transplant, but they may be candidates for lung, liver, lung, kidney, heart, and lung transplants. We are the only center who would be offering lung, liver, dual transplants in New York State. In fact, we were the first one to perform the lung liver transplant at Montefiore in the state of New York. We have performed 2 of them, and both are doing really well. And both those patients were referred from the liver transplant program from Mount Sinai because they have concomitant lung disease and they could not have received just a liver transplant. A BMI of greater than 35 would be a contraindication. HIV positivity in itself is not a contraindication, but manifest AIDS is. And active hepatitis B, C would be contraindications. Malignancy, a stage 1 or 2 malignancy, and which has been effectively treated, would still be considered for transplant, but typically if there is any greater stage than 2, then we would wait for 5 years before we consider for a lung transplant. The more common contraindications are psychosocial, steroid use, psychiatric reasons, compliance, pain, opiate dependence, surgical difficulties, and also chronic resistant infections. These are primarily because the referral of these patients was too late. For example, in a cystic fibrosis patients, they are always having recurrent infectious exacerbations, and we keep treating those infections repeatedly, ultimately we end up selecting a sebaceous complex, and that will not be a patient, that those will not be considered for lung transplantation in most centers. But we will look at those patients here at Sinai in a selected, uh, if otherwise they are excellent candidates, we will consider them. Organ allocation, what do we look in a donor and a recipient matching? Obviously, the lung allocation score, ABO compatibility, so, and size matching, donor PF ratio of at least 300. And if one of the lung is damaged, we may consider the other lung. Most of the times, a donation after brain death always has aspiration into the right lung, and left lungs are primarily selected for single lung transplant, at least in the last 3-4 years that I've been in Northeast, that's been the trend. What is the surgical technique? We anastomose the bronchus, the pulmonary artery, and the vein. Depends on single lung or double lung. It's a sequential. So we would first perform a pneumonectomy on one side and then perform the anastomosis of bronchus, pulmonary artery, and pulmonary vein. We would preferentially use veno-arterial ECMO as opposed to cardiopulmonary bypass in this day and age. And if they have a coexisting left main lesion or a LAD lesion, we would fix that at the same time of the surgery. Or if there is a VSD or a PFASD, we would close them at the same time of the surgery. This is important because our surgeon, Dr. Scott Sheinin, is primarily a cardiothoracic surgeon as opposed to a thoracic surgeon. So we are very comfortable in taking care of the concomitant cardiac issues during these surgeries. This is it. I would like to point out the time from when we stop circulation at the donor, and this is a nice donor lung. We use a perfusate to preserve the organ. The perfusate is a colloid-based perfusate, and the recipient pneumonectomy, and the explant lung, and a single lung transplant. We would like to perform that within 6 hours. 300 minutes is our limit, 300 to 360 minutes. This is actually a very, very rewarding surgery. Most patients just get off oxygen on day 2, day 3, and they have an excellent functional capacity immediately after the surgery. One of the patients who is on 10 liters of O2 with a PA mean of 47, pulmonary artery size is big, undergoes a lung transplant, right single lung, extubated post-op day 1, ambulating on 2 liters, and PA mean drops to 22 immediately because it's a good lung. It will allow the heart to, the right ventricle to decompress almost immediately. In a double lung, these are the explanted lungs, donor lungs. Many a times anesthetists would look at it and say, oh, they look as bad as the explanted lung, but these are atelectatic areas, so they look not so big. But when you perform, and we use a clamshell incision to perform a double lung transplant, and this is usually within less than 6 hours. These are some of our patients whom we have transplanted. The reason I'm sharing just these 2 patients are, this person happens to be a Jehovah's Faith patient, and we perform bloodless lung transplants. And she still has a swan and no oxygen, and she still has an NG, and she's able to ambulate immediately after the surgery. And this other young lady with the connective tissue disease and high PRAs, panel of reactive antibodies, which precludes our ability to match donor organs because our ability to have specific antibody reduction protocols, we were able to help this young lady. And both are at least 5 years out, and they're doing phenomenally well at this time. And this is our surgeon, Dr. Shannon, who has special interest in performing bloodless lung transplants, to the fact that he was featured in the New York Times front page in 2017 for performing a bloodless lung transplant in a patient from Houston. So far we have performed close to 100 Jehovah's Faith lung transplants with excellent outcomes. At least we did not lose a single patient within the first 30 days of transplant because we could not use blood products. And that's a phenomenal achievement on part of Dr. Scott Shannon and his surgical technique. What is that we offer to our patients at the time of discussion? The median survival is about 7.3 years after a double lung transplant, and after a single lung, about 4.5 years. And if they do survive the first 1 year, one can hope to live close to 10 years for median survival and 6.4 years for single lung. So most of the patients carry a highest risk of death within the first 1 year of transplant. That's why we follow them very closely in the first 1 year of transplant. Our induction regimens are monoclonal antibodies. Primarily, we use an IL-2 receptor antagonist. And our maintenance immune suppression is tacrolimus and mycophenolate are the primary immunosuppressants that we use. Post-transplant complications and the role of internist or pulmonologist is important. It is a multifold, all the systems will be affected. And these are unique to lung transplant. And the complications, I would quickly mention some: anastomotic, airway, and vascular complications of pulmonary disease. Atrial tachyarrhythmias are very common, 30 to 40% of patients, and they are recalcitrant. It's hard to control them. With triple therapies, we often end up going to EP for an ablation in most of the patients. Gastroparesis because of vagal injury and ischemic colitis are the dreadful complications that can account for mortality immediately after transplant. Renal failure and microangiopathic hemolytic anemias causing like a picture of TTP is unique in lung transplant. Hyperammonemia causes 85% mortality early post-transplant. And this is a dreadful complication. And infectious complication, which are unique. I'm sure every solid organ transplant program has a timeline of infections. The specific things I would like to point out for lungs are pre-existing colonization can cause problems, especially Pseudomonas and Aspergillus colonization. An aspergilloma in a chronic lung disease patient is not a contraindication for transplant. Some viruses, especially adenovirus and herpes viruses, can cause dramatic complications in the first few months. And after 6 months of transplant, mucormycosis. In the era of voriconazole prophylaxis, we often end up seeing mucor or Pseudosporium epiospermium or dread infections. As you try to protect patients with newer antifungals, you try to allow other bugs to grow. The Rhodococcus equi, especially in Kentucky, as you're all aware, a lot of people have, uh, they do have horses as pets. And Rhodococcus equi can present like a tuberculosis-like like an infection with nodules and can cause serious problems post-transplant. ECMO as a bridge to transplant. An ambulatory ECMO. This is a concept we would like to entertain in patients who have rapidly progressive lung disease, and we are trying to bridge them to a lung transplant. This is specifically for patients who have an isolated organ failure, especially in the COVID era of bad lung disease, and all other organs are preserved, and also they are young. So in those group of patients, we would definitely consider transplant. Ambulatory ECMO is real, and this can be achieved. It is cumbersome tech. A lot of people are involved to help this, but a awake ambulating patient of ECMO bridge has the same survival as a patient without ECMO. So that is the reason why we would like to ambulate patients. How long can you keep a patient on ECMO? This young lady was on for 170 days of ECMO, same circuit, same membrane, never changed the cannula. Had a lot of issues. She had a cardiac arrest during ambulation, but we persisted that she should ambulate. When she got the double lung, she stayed in the hospital for 8 days and she never turned back. So I'm sure every program has some successes. At the same time, we end up seeing some catastrophes with this intervention. This is obviously increasing across the globe, ECMO bridge to transplant. About 5 to 10% of all transplants are ECMO bridge. And to increase the available organ donor pool, there are these nice ex vivo machines that one can use to evaluate the suitability of a potential organ. And keeping a lung organ outside of the human body and getting blood gases, bronchoscopies, CAT scans in that box is a very beautiful technology that one can use to evaluate a potential organ donor and also determine the suitability for transplantation. The more one uses this technology, the more transplants one can do. There are two technologies available. One is the ex vivo normothermic perfusion. The other one is the transmedics one, where the organ is being ventilated immediately after you take it out of the lung. There are two systems available, and one can utilize them, especially in donation after cardiac death, DCD. And in those lungs, that can go on the machine, evaluate for suitability, and can definitely increase the organ pool. Other advancements are human bioengineering. And Jan Kasturga has published in mouse models that after injecting into damaged human lungs, lung stem cells form human bronchioles, alveoli, pulmonary vessels integrated structurally and functionally within the damaged organ. Bioengineering of lungs is real, and eventually we would have something like this coming up to address the need for organ scarcity. Everyone has good stories to share. This is me, my patient, 76-year-old, 10 years post-transplant, doing a tandem dive. People can have a wonderful quality of life after transplant. And My last slide, promoting organ donation really saves lives. And this is the end of my talk. Happy to take questions.
Great. Thank you very much. Let's see if we maybe people can put some questions in the chat. Oh, let's see. Sachi, Dr. Dua made a comment. Thank you for the talk. New hope for old diseases. Other questions?
I don't know if Dr. Shannon is online, and I'm hoping if he can add a couple of words. Dr. Shannon, are you? Scott?
Maybe we could see if he's on, but Sachi also asked a question, how do you feel about MAI colonization in listed patients?
Oh, that's a great question. Colonization or infection. Recently, we performed a double lung transplant in a post-BMT bronchiolitis obliterans patient who had MAC and M. abscesses. And there were a couple of surgical techniques we use intra-op to prevent resurgence of the infection. And a patient who has MAC and who is being actively treated for MAC will always be considered for lung transplantation. And colonization is not a contraindication. Active disease, which is well controlled, will still be an indication for lung transplant.
Dr. Powell's a question, what are the major barriers to lung transplantation having the same long-term outcomes as other solid organs, and how can we at Mount Sinai help to impact outcomes?
Oh, that's a great question, Dr. Powell. Bronchiolitis obliterans, chronic rejection, and the immunological pathways that lead to progressive loss of the allografts is a major challenge across all lung transplant programs that accounts for most of the long-term mortalities of these patients. And our ability to understand the pathophysiology and identify appropriate timely interventions in this group of patients would dramatically impact the field of lung transplantation. That's one. And organ preservation and organ donation, promoting organ donation is also very important for our tri-state area. And any innovative approaches to increase the available organ donor pool would be very helpful.
There's another question. Does the size of the transplant program correlate with the benefit for the patient's survival?
Yeah, I mean, the more, if there is a, when we say about the size of the program, yes, it does impact the survival. It's primarily the factors pertinent to that in 3 publications are the general awareness and the ability to identify a complication in a timely manner and address it. I'm giving an example of hyperammonemia. If we end up with this patient, these patients need emergent neurosurgical intervention, cerebral decompression techniques to help until the injury resolves. If we do not do that and we lose time and there is no scope for the patient. The same thing is with the ability to bridge them on ECMO. Everyone sees complications, and one's ability to urgently, emergently identify the complication and bridge them on ECMO is vital for a success of a program. At large, if a program does 30 plus lung transplants per year, they would have a slightly better outcome than otherwise. At the same time, Dr. Shinen can share, because he sits on the membership for professional standards committee, reviews program adverse outcomes. One of the largest program in our country had to go through a major serious adverse event not so long ago. And just because you do more transplant doesn't automatically translate into better survival. Mostly it's about one's ability to identify complications in a timely manner and address them effectively is what determines the success of a program and improved survival.
There's another question. Does lung transplant take a village? And if so, what are the key elements that the program offers for evaluation and treatment of patients with severe lung disease?
Fortunately for us, we have several advanced lung disease service lines, like a strong ILD program, a strong PH program, and dedicated physicians are making concerted effort in evaluating, managing, and timely bridging them towards lung transplantation. And yes, it does take a lot of effort in getting people agree upon the timing of intervention and when would transplant be an absolute contraindication or it's a futile effort. So fortunately, Dr. Padilla and Dr. Dua have participated, did run a program a few years ago, and they're very supportive, and they do see what would be the right time to bridge a patient to transplant as of now. So we are fortunate to have them in our section. So we hope to continue to engage them actively in even the bone marrow transplant folks with bronchiolitis obliterans and every other person. It's work in progress until we continue to strive and do better and better. And it will always be a work in progress, in my view.
Great. We're trying to unmute Dr. Shiner, but we can't do it. So sorry about that. Any other questions? All right. Well, it's great to have you here, Dr. Seethamraju. It's really great to have this program here. It's very impressive. Thank you very much. And thanks to Cap and his team in pulmonary for bringing this really important component to our medical team here at Sinai. So wonderful to have you. So thanks everyone. Thanks everyone. Have a great day.